Welcome to Pediatric Podcast for PedsCases.com.
Hi, my name is Jose Lopez-Vera, a fourth-year medical student at the Western Michigan University Homer Stryker MD School of Medicine, also known as WMed, in Kalamazoo, Michigan, USA. This Peds Cases podcast on approach to a child with intellectual disability was developed with the help of Dr. Neelkamal Soares, a developmental-behavioral pediatrician and professor of pediatric and adolescent medicine at WMed.
After this podcast discussion, the learner will be able to distinguish between developmental delay and intellectual disability, articulate the rationale for genetic testing in children with developmental delay or intellectual disability, TD or ID, and discuss some of the findings in patients with FRAGILEX syndrome. Let's start this podcast with a case. A 5-year-old boy comes to the pediatric outpatient clinic with his mother for a school physical. He is new to the clinic and his mother brings his previous medical and educational records with her. He has no current illnesses or concerns, and the family history is unremarkable. His previous pediatrician, who had been seeing him since birth, found him to have developmental delays at age of 4 years and referred him for educational testing and ordered genetic lab work. He was found to meet criteria for intellectual impairment based on an IQ or intellectual quotient composite score of 61 with an adaptive rating of 63. The genetic testing done showed a negative chromosomal microarray result and a FRAGILEX molecular test result of 240 CGG triple repeats. After seeing this patient and reviewing the documentation, the medical student presents the case to the attending physician. Here is the outline of the discussion around the case.
Hi, doctor. I just encountered a patient with developmental delay in clinic.
Thank you for seeing the patient. I'd be glad to hear about it. Where should we start? Would you like to present the patient formally to me?
Absolutely. The patient is a 5-year-old boy who presents to our clinic with his mother for a school physical. He is new to our clinic, but his mother brings his previous medical records and education records with her. From these records, he has a history of developmental delay at age 4 and was subsequently referred for educational testing and lab work was ordered. He was found to meet criteria for intellectual impairment with an IQ of 61 and an adaptive rating of 63. The genetic testing done showed...
Wait. Let's stop there and discuss the tests and results later. That was a very good start. We can also discuss your physical exam findings later. For now, let's talk about intellectual disability. First off, what does the IQ of 61 already tell you? And what is your differential diagnosis for this in a 5-year-old?
An IQ of 61 indicates mild mental retardation. The differential diagnosis for that includes autism spectrum disorder, or ASD, cerebral palsy, or CP, FRAGILEX syndrome, learning disorder, Rett syndrome, seizures, and I'm sure there's more, but I can't remember the rest right now.
Good. Now let's talk about intellectual disability.
Sure. What about it?
Well, what does it mean?
Well, according to the American Association on Intellectual and Developmental Disabilities, or the AAIDD, or AID, intellectual disability is characterized by significant limitations both in intellectual functioning and in adaptive behavior as expressed in conceptual, social, and practical adaptive skills. This disability originates before the age of 18.
Do you know what term they used to use? You just said it earlier.
Mental retardation?
Exactly. Try not to use that term anymore, as it has been replaced. Mental retardation used to be the preferred term, but in 2007, the AAIDD substituted it with intellectual disability. They changed the name according to certain criteria. First, it reflects the changed construct of disability as described by the AAIDD and the WHO, or World Health Organization. It just aligns better with current professional practices that focus on functional behaviors and contextual factors. Also provides a logical basis for individualized supports provision due to its basis in a socio-ecological framework, is less offensive to persons with the disability, and is more consistent with international terminology.
Interesting. So let me get this straight. Developmental delay is still different from intellectual disability, right?
That's right. And global developmental delay, or GDD, is the failure to attain expected developmental milestones in two or more areas of functioning. Not all children with GDD are found later to have intellectual disability.
And ID is usually identified later than GDD, after age 5, right? And is usually chronic in nature. A child may be delayed in a certain area, but later catch up and have no delay or disability.
Very good. GDD is diagnosed when children are too young or too impaired to undergo systematic assessment of various levels of functioning. So, let's say you suspect a child in your clinic to have ID. How are you going to go about diagnosing it?
Well, I know that there are DSM-5 criteria for the diagnosis of intellectual disability, but I can't remember exactly what they are right now.
You are correct, there are. So the DSM-5, or the Diagnostic and Statistical Manual of Mental Disorders 5th edition, specifies that there should be deficits in intellectual functioning, which is reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and learning from experience, and practical understanding, confirmed by clinical assessment and standardized testing. There should also be deficits in adaptive functioning that require ongoing support, as they interfere with functioning in one or more activities of daily life, such as communication, social participation, and independent living across home, school, work, and other settings. Also, these deficits occur during the developmental period, generally considered childhood and adolescence. So, are you qualified as a pediatrician to diagnose ID?
I believe so. Aren't physicians qualified to do so?
Well, physicians, both primary or subspecialist physicians, may identify deficits in adaptive functioning, either by administering questionnaires for this or by reviewing previously collected data. But generally, psychologists, clinical, educational, or neuropsychologists, conduct the actual intelligence assessments and also conduct adaptive assessments. This can vary in other countries based on local regulations and standard of practice. One thing that should not happen is that ID should not be diagnosed purely on somebody's opinion or non-standardized testing or just a history of delays. Often, even if a diagnosis is made, it should be looked at again, revisited after a period of time, generally 2 to 3 years, to ensure the stability of the diagnosis, that the person still meets those criteria. The other thing to remember is that the educational qualification in school systems of intellectual disability might not be the same as the medical diagnosis, because different systems use different criteria and different nomenclature. So this is something for clinicians and families to be aware of.
So, now that we have diagnosed intellectual disability, what about my patient? He does not have any classic features of any syndrome, and I don't want to jump to conclusions regarding a diagnosis, but I read that FRAGILEX syndrome is one of the most common genetic conditions associated with ID.
Very good. Let's dive into this. But before we get into the specific tests for the diagnosis, let's talk about the condition itself. What is FRAGILEX? Is it common?
Well, from a quick read I did last week, I learned that it has a prevalence of about 1 in 3,600 to 4,000 in males, and 1 in 4,000 to 6,000 in females. It is lower in females because females with a full mutation also have another normal X chromosome. 1 in 151 females are carriers of the premutation, and 1 in 468 males are carriers of the premutation.
Very good. Now, can you tell me what it is?
From my reading, I learned that FRAGILEX is a genetic condition that causes intellectual disability, behavioral and learning challenges, and various physical characteristics.
Great. Any physical characteristics that you can see?
Now, our patient had no significant physical exam findings, but in patients with FRAGILEX, depending on the age, they can have typical features that vary from patient to patient. Facial features including large ears, prominent jaw and forehead, and a long face. Other problems that can be found are connective tissue problems like strabismus, flat feet, high arched palate, mitral valve prolapse, double jointed fingers, and hyperflexible joints. In adolescents, there can even be large testes.
And as we know, FRAGILEX isn't just associated with physical findings. What are some of the neuropsychiatric features? Can you name any?
Sure, kids with FRAGILEX can have ADHD, autism spectrum disorder, social anxiety, sensory disorders, and significant ID.
Yes, and they can also have behaviors like hand biting and or flapping, poor eye contact, and aggression.
It's generally milder in females, right?
Yes, that's correct. Females can have learning disorders more so than ID. Now let's talk about how you are going to go about diagnosing this child and narrowing the differential diagnosis. What tests are you going to order?
I might get a karyotype, maybe a PCR looking for a specific gene for FRAGILEX. I have the results he came with. His genetic testing showed a negative chromosomal microarray, which, if I remember, is a sensitive test used initially to investigate GDD, and it consists of a computer chip analysis of DNA, using molecular probes to diagnose deletions and duplications of whole chromosomes, portions of chromosomes, and specific locations associated with particular genetic diseases. The other is FRAGILEX molecular test, which showed 240 CGG triple repeats. So it looks like he had a PCR done. But why not a karyotype?
Actually, the two most common genetic tests for FRAGILEX today, Southern blot and PCR, have largely replaced karyotyping for the diagnosis of the disorder. Can you tell me what we are looking for in these specific tests?
Well, I know that FRAGILEX is a triple repeat disorder, like we said earlier, and the sequence is CGG in the FMR1 gene. I can't really tell you much else right now.
That is an excellent base of knowledge to build off of. The FMR1 gene encodes the Fragile X mental retardation protein, or FMRP, which is a regulatory protein that binds mRNA in neurons and dendrites. In a full mutation, FMRP is not made due to hypermethylation of FMR1. Brain development is impaired due to abnormal synapse connections, and it can also lead to excessive activity of the metabotropic glutamate receptor 5, or mGluR5, which results in many FRAGILEX symptoms in other tissues. But before we discuss the CGG repeats, let's go back and talk about how we test for FRAGILEX.
You mean like Southern blot and PCR?
That's right. Southern blot tells if the gene has a full mutation, approximate size of the mutation, whether the gene has been methylated, and if there is mosaicism of the gene. PCR can determine the actual number of CGG repeats that are present in the FMR1 gene.
Oh, now I remember from my reading. Certain numbers of repeats indicate different severities of the disease. The more repeats, the more severe the mutation, right?
That's right. 5 to 44 repeats indicates a normal, unaffected individual. Patients with 45 to 54 repeats are unaffected but are at risk of passing it on to their offspring, hence it's considered an intermediate or gray zone. Patients with 55 to 200 repeats have a pre-mutation, and more than 200 repeat indicates a full mutation. Males with a full mutation have Fragile X syndrome, and their mothers almost always have a pre-mutation.
Wow, our patient had 240. That means he has the full mutation and the disease.
Unfortunately, that's right. You got the diagnosis right. His mother has the pre-mutation as well. Why do all of this? Why not just have Fragile X be a clinical diagnosis?
Well, lately, the diagnostic yield has increased substantially from genetic testing, from about 8% to 35% according to a study I looked at, likely due to improved technologies. Families get more educated about not only the diagnosis, but the process moving forward during treatment and what to expect. The tests are for establishing diagnosis, not confirming them.
I'm very impressed. Now, all this talk about trinucleotide repeats, what exactly are they? can you think of other disorders of trinucleotide repeats?
Sure, for starters, trinucleotide repeats are normally occurring repeats in several genes. When they are not replicated correctly, they result in disorders. When the repeats exceed normal stable threshold consisting of unstable microsatellite repeats, it increases the number, making the gene defective. Other diseases I can think of, let's see, Huntington's, Friedreich's ataxia, myotonic dystrophy, I'm sure there's others as well.
I'm impressed. There are others. Spinocerebellar ataxias, spinal bulbar muscular atrophy, SBMA, just to name a couple. Okay, now that we have a fundamental understanding of the disease, we need to treat this patient. What other medical workup is necessary for FRAGILEX patients?
Well, I read that these patients can also develop other medical conditions such as GERD or gastroesophageal reflux disease, OSA or obstructive sleep apnea, strabismus and refractive errors, recurrent sinusitis and otitis media, decreased visual acuity, scoliosis, mitral valve prolapse. There's actually an American Academy of Pediatrics guideline on the appropriate health supervision of patients with FRAGILEX syndrome, which is really helpful. The guideline breaks down the health supervision into ages. For the 1 to 5-year-old group, the guidelines include evaluation for ophthalmologic and orthopedic problems, inguinal hernias, seizures, recurrent otitis media, as well as monitoring for receptive and expressive communication, emotion and behavior, psychopharmacologic interventions, linear growth monitoring, facial structure changes, sleep disturbance or apnea, and delayed toilet training.
Yes, these patients often develop other problems, and it is important to monitor these. In addition, there are 2 late-onset conditions to be aware of, especially in those with pre-mutations. One is called Fragile X-associated tremor ataxia syndrome, or FXTAS, which involves white matter lesions on MRI scans with intention tremor or gait ataxia clinically. The other, only seen in females, is FMR1-related primary ovarian insufficiency, or FXPOI, which is cessation of menses before 40 years.
All right, I'll try to read more about that, but it is generally in adults, not children, right?
Correct. Now, on the topic of treating these patients, who else is involved? Are you going to do everything yourself? Does FRAGILEX have a cure?
Unfortunately, like most other genetic disorders, there is no cure, only symptomatic treatment, of which I hope I don't have to manage all by myself. It seems like a lot, I'm not really sure, but I imagine these patients qualify for special education and other types of therapies. Thanks to the help of many allied health professionals involved in the treatment, growth, and development of the patient, the job is made a bit easier. These include speech-language pathologists, occupational therapists, and teachers in school, the family, and so on. It is important to integrate the various roles together in the care of the patient throughout different settings like school, home, and the medical home, and mental health and therapy.
Absolutely. They usually have help from other professionals that aren't necessarily doctors. But of course, the majority of their care comes from the family. It is important that these patients receive the exact same health care and surveillance that any other child would, as mentioned earlier in the AAP guidelines for the age group. Now, do you have any questions about FRAGILEX that we haven't discussed yet?
No, I think that just about covers it. We just have to also remember to make sure that the family understands every step of the process of management. Thanks so much, Doctor.
Absolutely. The family is the cornerstone of all of this. I hope this was useful.
Invaluable. Thanks so much.
No problem. Now let's go see this patient together. And let's summarize a few key points. The term mental retardation is archaic and now replaced with intellectual disability or ID. Global developmental delay or GDD is the term used most often in younger children and those with less severity. Genetic testing is indicated in searching for diagnosis in ID and GDD. FRAGILEX syndrome is the most common inherited cause of ID. FRAGILEX has many disease manifestations: physical, cognitive, psychosocial, and has no cure. An interprofessional approach is often required in the care of individuals with FRAGILEX syndrome with the family and patient at the center of it all.
Thank you for listening to this PEDS Cases podcast on the approach to a child with intellectual disability. Stay tuned for more PEDS Cases podcasts.
Check out www.pedscases.com for more great podcasts, videos, interactive cases, questions, and more. Press subscribe on iTunes to get access to all of our podcasts. If you like what we do, please leave a review on the iTunes Store, share with your friends and colleagues, or think about getting involved.